you? Gotcha. Cool. Thanks very much. Your second page, aren't you? Yeah. But I don't remember.
122, 122.
Perfect. Thank you. Hi, Chantal. Cool. Thank you. Oh, and Hamad, I saw. Hamad, I saw you. So you're good. Anna. Yeah. Cool. Thank you. Second page. I think I checked you off already. Oh no, I didn't. Sorry. Damn. Okay. Hey, Miriam. How are you? How are things? Good. Okay, you're doing okay? Okay. You know where I am if you need me? Yeah? Just talk to me if you need to, okay? Okay. Perfect. Yeah. Perfect. Thank you. Your second page. Are you at the top? Perfect. Thank you very much. Hi. Yes. Second page? Yes. Right there. I knew. I was like, I knew I'm on the right page. Okay, perfect. Let me do your first page, though, aren't you? If you see it, shout. No, your second page at the top right. Yeah. Sorry. No, I have you checked already. Oh, no, I don't. Yeah. Thank you. I was like, you know what? I saw you earlier, and I was like, in my head, I had you mentally checked off, but not physically on the paper. Hello, how are you? You are down here somewhere. Second page, yeah, I know. I just have to find you. Oh, yeah. I just scan through all the names, and I can never find anyone. So you're the first page, right? You should say second page. No. Yeah. Thank you. Hello? Did you? A lot? Good. Okay, good. Okay. Okay. You're first page, aren't you? Yeah. Yeah. Perfect. Thanks. Yeah. You know, oh yeah, when can we do it? Because I just realized there's a meeting I should go to, but I don't have to go to, and I don't really give any warning. So I can do it at minus, no problem. Yeah, is that better? It's probably more helpful. Yeah, okay, that's no worries, yeah. Thank you, Tamara, how are you? We are going to meet tomorrow in clinical skills room for the two-parters. I'll send an email out, but they only just emailed me to tell me, so yeah, is that okay? Oh, no, well, can we do it beforehand? Do you want to do it before? Like after your internal teaching, we can do it then? That'd be easier? That finishes 10:30 to 11:30, right? Or are you going to miss that to be in for your appointment? Okay, I don't want you to have to come back out there. That seems too much. Could we do it before the 8 a.m. teaching? Yeah? Could we wait for like 10 minutes before the 8 a.m. teaching? Okay, I'll try and remember. I'll probably forget. But I'll remember to bring your email me, and I'll bring the sheet with me. We can just do it beforehand. Yeah, no, it's silly to make you come back, so that's no worries. Yeah, of course. Hi, how are you? Hi, you're second page, right? Yeah. If you see it, yeah. I'm like blind. Oh yeah, thank you. You don't understand. Like they all I feel like I have some type of dyslexia, which I don't. But when I try to find a name, I just never see it. I go through it. Yeah.
I just have one other question for you. I sent you an email from AWS about
you did?
12.
Yes.
Is that okay? Are you happy to do that?
Yeah. I just didn't get a chance.
No, I figured it's quicker. It was kind of a random email, not important, so I figured
Yeah, no, and I just haven't had a chance to come back to him. He is, but I'm going to see if either one he'll let me do it, because I can do it at 2, or if he'll do it at 3.
Hi guys. Hey, can everyone hear us? Is there anyone in Drogheda or Waterford, wherever that is? Yeah, you can hear? Great. Good stuff. Is there only one person there? No, two. Hi guys. Thanks for coming. Okay, so today's OSCE session is going to be slightly different. It's a little bit more practical. So we've Dr. Ciara Goff here, who's a respiratory SPR, and we have an advanced nurse practitioner in respiratory medicine as well, Helen, who's going to go through basically the CPAP, BiPAP kind of pathways, go through the machines, how they work, and kind of talk to you a little bit about how that might be relevant to, say, your OSCE exam as well as to your practice on graduation. So obviously hugely prevalent. You'll be asked to follow BiPAP pathways as interns on call, so it's really important to kind of wrap your head around it now. And also it's, to be honest, it's something that we could ask you about in your OSCE, and Ciara will go through the kind of scenarios that you could be asked about. Now obviously you would never be asked to put a patient on it in an OSCE, or you'd never even be asked to fit it on a mannequin or anything like that, but we will go through with you this morning how you would do that. And it's more to do with questions about it, correctly identifying the equipment that's in front of you, and adjusting settings. So Ciara's going to go through it in a little bit more detail, and then Helen's going to go through the actual kind of practical aspects of using the machines, and then everyone can come up and have a look at the machine and practice fitting it on or whatever you'd like to do from there. Is that okay? Great. So Ciara, if you're ready to go there, that's great. Ciara has some slides to go through just to kind of just one sec, sorry, just to kind of give you a broad overview of the topic.
Okay, so, right. Okay, I won't lie, I was looking forward to doing this session because I think this is a really, really important topic in particular. So this is focused on non-invasive ventilation. So it's fixing acidotic type 2 respiratory failure with non-invasive ventilation. For your exam and for your practice as interns, there is one indication for NIV in the hyperacute setting. NIV or BiPAP, the terms are interchangeable. That is acidotic hypercapnic respiratory failure. Don't, as somebody did in TASPA yesterday, put somebody on NIV or elect to put somebody on NIV for type 1 respiratory failure. You are creating a lot of hassle overnight. But the slides here are just going to be a very brief introduction to respiratory failure and NIV. It is not new material. Most of these slides are pulled from your consolidation lecture that incorporated respiratory failure, and your PFTs and ABG lecture as well. So none of these images should be particularly new to you. Okay, so ignore this title slide because I just like the image. I really liked the image, so I decided to use it, but it's not really particularly relevant for you. Okay. The respiratory system, I should say, has two functions, and the two functions are combine into gas exchange. So you got to get oxygen in, and you got to get carbon dioxide out. If not just your lungs, your respiratory system, so your nares down to your diaphragm, including your chest wall, if they cannot get carbon dioxide out, you are going to get sicker much quicker than if the only problem is hypoxia. It's why I really I focus a lot of time and energy on teaching, in particular junior NCHDs, when I'm in my clinical role. So I spend a lot more time talking about NIV because pH is much more important than what your PaO2 is doing. Does hypoxia kill people? Yes, absolutely, it does. Does acidemia kill people faster? Yes, it does. So really the focus on this is identifying a device that is non-invasive ventilation that treats respiratory acidosis. So when I think of respiratory failure, and the way I always teach this is if you look at an ABG as a cheat, and we did this in your consolidation, in the consolidation lecture, if you look at the ABG, and the only problem on that ABG is the PaO2, and the PaO2 is less than 8 kilopascals, that is type 1 respiratory failure. Type 1 respiratory failure is here. It's a failure of the lungs to oxygenate. That's it. There shouldn't be any problem with the diaphragm. There shouldn't be any problem with any component of the neuromuscular system. It is just a failure to oxygenate. That failure to oxygenate can arise as a result of damage to any structure within the substance of the lung. So an airway, an alveolus, the pulmonary blood gas barrier, or the interstitium. Any of those are up for grabs when you're running through a differential or you're trying to generate a differential for type 1 respiratory failure. But the only problem on the ABG is going to be a PaO2 of less than 8. You need to remember a PaO2 of less than 8 for lots of reasons, because clinically it's really important. But once somebody gets to a PaO2 of 8, very, very tiny changes in their PaO2 are going to cause big desaturations. When you're interns, you're going to be plagued by going up to review patients who, in particular, have COPD, where they walk to the toilet, they come back, the nurse checks their vitals, and their SATs are 80%, and it's all of a sudden desat, doctor. And the only reason they've desaturated suddenly is because their PaO2 hovers at around 7.5 to 8 all the time, and as soon as they start to move, they start to desaturate very rapidly. What we are interested in is, so forget about that for the time being. What we are interested in is when that lung failure occurs in concert with failure of the respiratory muscle pump. The respiratory muscle pump fails for a lot of reasons, but the most common cause that we see is people with COPD. You don't classically think of, oh, it's a pump failure when somebody goes into ventilatory failure with COPD, but it absolutely is. When we teach you what hyperinflation looks like on a chest x-ray, the reason that we do that is if you see a really flat diaphragm, your diaphragm should be a nice, big, lovely dome. A really flat diaphragm is not going to generate swings in intrapleural pressure that are necessary to ventilate. So what we are focusing on is treating this, a ventilation problem. It's not just oxygenation, it's ventilation. Full, efficient inspiration, full, efficient expiration. So if you look at an ABG, again, a cheat, if you look at an ABG and the PaO2 is less than 8 kilopascals, that's your cutoff for respiratory failure. You know they're in respiratory failure. Now you want to know, is it type 1 or type 2? You're going to look at the CO2 and the pH. If the CO2 is elevated, they are in type 2 respiratory failure. Then you want to know, are they acidotic or not acidotic? Because they are very different beasts. The ones that we're focusing on, the ones that we are talking about today, are the acidotic hypercapnic respiratory failure patients. The ones with chronic hypercapnia, you as an intern, you as an SHO, you as a reg overnight, you don't need to worry about putting those patients onto non-invasive ventilation. You need to give them targeted oxygen to keep their SATs tightly at 88 to 92%, and then you get a respiratory consult the next day to see would they benefit from a bit of ventilatory support overnight. But they do not need NIV in the acute setting. If you get a long case and somebody is talking to you about ventilatory failure or respiratory failure or starting somebody on long-term oxygen, if they're chronic hypercapnics, they do not need emergent NIV, they need consideration for nocturnal NIV. And even then, not all of them get it. Okay, so type 2 respiratory failure, once you identify that the CO2 is elevated, what you really care about is the pH. And in practice, so when we're teaching you how to interpret ABGs as students, we're quite formulaic in how we teach it, in that you're saying, well, look at the PaO2 first, is it low, is it less than 8, then look at the CO2, then look at the pH. In reality, when you're practicing, when you're an intern, particularly as you move up and you get a bit more senior, the first thing you're going to look at above anything else is the pH, because acidemia, whether it's a metabolic origin or respiratory origin, acidemia kills people. So the ones that we are talking about today are these guys. So it is an acute failure to ventilate. It can happen in somebody who is chronically hypercapnic, absolutely, or it can happen in somebody who's not hypercapnic and they've developed ventilatory failure. How does it develop? So if you want to understand how non-invasive ventilation works to fix the problem of ventilatory failure, you kind of need to have an idea of how ventilatory failure, particularly within COPD, because that's the majority of patients that you're going to be putting on NIV when you're interns, how ventilatory failure actually develops. So you'll all have seen those diagrams at various stages of airways, Netter has a few nice ones from COPD and asthma, where you see these very kind of thickened, excessively muscular but still floppy airways that are lined with mucus. That's what a COPD airway looks like. You transect through an airway. The thing with COPD is some people will be more emphysematous, some people will be more bronchitic. Either one, COPD is very much a mishmash. No, I can't even say it. It's a mix of emphysema and what we used to know as bronchitis. When somebody with COPD is sick, the central problem is that they can inhale more than they can exhale. They can't get an entire breath all the way out. So when they go to expire, those very floppy, mucus-lined airways collapse. You've got air rushing out, air goes in, fine. Air is going out, and the small airways are collapsing down. If your small airways are collapsing down, you're going to trap gas behind the collapsed airway. And that's what we mean when we talk about gas trapping. When somebody with COPD is sick, and particularly when they're tachypnic, that is it's kind of a self-fulfilling prophecy. They get stuck in, it's frequently described as this ratchet effect, where you've just got that pressure, that gas trapping building up and up and up. Every breath you take, if you can't get everything out, you're going to start to build up a lot of positive pressure in the chest. It is analogous to you sitting there now. If you take a big breath in, and then you try and breathe normally or comfortably on top of that, it's very difficult to do. That's what's happening in COPD. They have all of this positive pressure built up within their chest that they must overcome when they draw the next breath in, but they can't do it. It's why when you see them coming in A&E, first couple of times you see this, it'll strike you. And also, actually more so, arguably, a hypercapnic asthmatic. There's no mistake in them. They work really, really hard to try and blow off their CO2. The problem is it's not effective. Their airways are collapsing on them. They just cannot do it alone. If they're left like that for long enough, their CO2 will go so high, they become drowsy, and then they can't ventilate themselves no matter how hard they try. So that's what you're trying to avoid. That's the cycle that you're trying to break. If they retain CO2 for long enough, CO2 is going to combine with water and it's going to generate carbonic acid. That's what makes you acidic. That's what makes their pH go down. That's what you're trying to break. So what's the solution? Solution is non-invasive ventilation. NIV and BiPAP, use the terms interchangeably. BiPAP, BPAP, bi-level positive airway pressure, it's a trade name. It is more correctly referred to as non-invasive ventilation. BiPAP has 2 pressure levels. CPAP is different again. CPAP has 1 pressure level. We use it for patients with obstructive sleep apnea to splint open their collapsing upper airway. And we use it for patients in pulmonary edema. It is not relevant to this talk. If you have a patient with COPD and chronic ventilatory failure or acute ventilatory failure, CPAP is not in the armamentarium. Move away from it. Forget about it. Keep it in reserve. It's pulmonary edema. CPAP does not ventilate a patient. If you want to ventilate somebody, you must have 2 different pressure levels. 1 single pressure level is not going to do it. So BiPAP, how you remember it, memory aid, it's 2 pressures, so bi-level, 2 pressures, IPAP, which is high, EPAP, which is low, so the inspiratory positive airway pressure, expiratory positive airway pressure, and it fixes 2 problems. Those problems are pH and CO2. What you are interested in is how it fixes the CO2. When I say it fixes 2 problems, I've included that as a memory aid because bi-level, 2 pressure levels, 2 problems. But it also will fix the oxygen. It fixes the oxygenation over time, and for reasons that I'll explain now. So how NIV works. If you imagine your lungs as, particularly so if you've got somebody with COPD, they have all of this resistance that they have to overcome because they have this what's called intrinsic PEEP, positive end expiratory pressure. When they get to the end of expiration, rather than the intrathoracic pressure being atmospheric or subatmospheric, allowing them to take in a breath normally as you would, they have a higher than atmospheric pressure within the thorax. They have to work really hard to overcome it. So what the IPAP does, the higher pressure in BiPAP, is it overcomes that resistance. It takes that work of breathing away from the patient. If you can reduce their work of breathing and slow their respiratory rate by doing that, you are going to reduce the amount of gas that they are trapping. So then what the EPAP does, or why the EPAP is there, is really to look after the oxygen. So the EPAP, it really does 2 things. It makes it easier to ventilate your patient, and it fixes the oxygen. How it fixes the oxygen is probably theoretically easier to understand. So if you imagine the EPAP, you have this high inspiratory pressure, then your patient cycles into expiration and you're still applying pressure. The reason is a lot of what drives hypoxia in COPD. So you've got somebody who's got a pneumonia, big consolidation, they've got all of these small airways just compressed by surrounding atelectatic tissue. What the EPAP does is it splints open those small airways. If you are leaving a little bit of pressure within the thorax, it's going to start to recruit those small airways over time. If you recruit the small airways, you are now opening up connections to the distal alveoli, and you are going to improve VQ matching. The other thing is, or why it makes it easier to actually ventilate your patient, so why it makes it easier to drive up the size of their breath, is if you imagine you let all the air out of the balloon. If you have to go and inflate it from scratch again, it's just more work. If you leave a little bit of air within a balloon, it's much easier to inflate and deflate it on top of that small bit of air. And that's how the lungs work. It's the same principle if you're invasively ventilating somebody. The key thing with NIV, and what differentiates it from CPAP, is pressure support. So the terminology can get a bit confusing here. So what I would advise you is to stick solely, when you're trying to understand this, is to stick solely to the terms that are used here. The difference between the IPAP and the EPAP is called the pressure support. It's what actually supports the breath. When you are prescribing non-invasive, what you are prescribing is pressure support. The absolute level of the IPAP and the EPAP is much less important than the difference between the two. The difference between the two governs the size of the breath. So big, high IPAP inflates the balloon, let it all out to the EPAP. The difference between the two will govern the size, the tidal volume, the size of the breath that your patient is taking. Ultimately, what you want to do in COPD is you want them to be taking bigger, more effective breaths. So if you increase the difference between the two, that's what's going to allow your patient to blow off their CO2. If you put the IPAP and the EPAP really, really close together, you are mimicking CPAP. You're losing that ventilatory support. Don't do it. If you want to get rid of CO2 and thus fix the pH, when you change the settings, you need to increase the difference between the IPAP and the EPAP. Now, I know some of you are sitting there going, is this a bit nebulous for me, or am I going to have to do this when I'm an intern? Should I understand this? Do I need to understand this as an intern? And the answer is yes. The reason that I got interested in this topic was because of a bad experience as an intern, largely. I was on call for medicine, found myself in Phoenix ward. The respiratory SPR had seen this patient. He had a strangulated hernia, vomited, background of COPD, an aspiration pneumonia, had been okay, wasn't acidotic, but was very tachypnic, and he had a plan, do the ABG in 2 hours. If he's acidotic, put him onto NIV. Delighted, I thought, because there was a nice, clear plan in place. The machine came up to the ward, and nobody knew how to start it. Then when we did start it, and I phoned the reg to ask him what to do with the settings, he hadn't a clue what to do with the settings. This is kind of an orphan topic for the last 10 years or so. I promise you, when you were interns, you were going to be seeing these patients all the time. It's the reason why we do one of these scenarios in your SIMS. Perhaps to really light the fire under you, I'm going to say that this is, of course, examinable. We have put a lot of time and effort into teaching you about NIV and teaching you about respiratory failure, in particular ventilatory failure, so absolutely this is examinable. It is not a difficult topic, and it will stand to you when you are interns, no matter where you're working. Okay, this is just how you prescribe pressure support. If somebody asks you to prescribe settings on NIV, what you are going to do is increase the difference between the top and the bottom number. What you start on really comes down to how likely your patient is to tolerate non-invasive. You're going to have an opportunity to put the mask on if you want. You're going to feel like it's for a non-invasive therapy. It feels about as invasive as you can get. Now imagine you're septic, you're sick, you're feeling really unwell, you're struggling to breathe, and somebody straps you into this contraption. If you put somebody straight on at really high pressures, I'm talking 30 on 8, you might lose them. You might just lose them because they say, no, don't come near me with that thing. It feels terrible. It's way too severe. I don't want it. To avoid that, you start at lower pressures. So 12 and 4, 15 and 4, reasonable. You should bear in mind if you have a very big patient, so patients come in all shapes and sizes, as we all do. If you put 12 and 4 on a very small 55-kilo lady, and then you put the same settings on a man with a BMI of 40, they're not going to ventilate as effectively in your bigger patient. So that is something to bear in mind. What you need to know, okay, so when you're studying NIV, or you're thinking, I need a few high-yield facts on non-invasive ventilation, or what is going to cover me for my MCQs, cover me for my OSCEs, cover me for any aspect that might arise during questioning, in particular for the long case, this is what you learn. This is a pathway that we have here in Beaumont. We'll hand out some paper versions of it to you. patient needs to go on to non-invasive ventilation in Beaumont, this is what we use to guide the decisions that we make. It reads from left to right across the page. If you don't have an indication for it, then you don't move on. You don't use this pathway. But you will see very clearly there the indications, the contraindications. There are very few absolute contraindications for NIV. Most of them are relative, but the absolute ones are given there: facial deformity, burns, and a fixed upper airway obstruction. Everything else, severity of acidemia, low GCS, they're all relative. I promise you, so pH less than 1.5, you will start patients who are more acidotic than that on NIV, where their ceiling of care is they're not going to ICU. ICU are not necessarily going to be involved with your patient. When we audited this in Beaumont, ICU were involved in about 30% of these cases. So there are still a lot of patients who require NIV who are managed solely by medical teams, and one day, in particular when you're medical registrars, that will be you. This is what you need to record before you start somebody, or when you're prescribing, what you need to request. Everyone should have an up-to-date chest x-ray. The reason being, you don't want to miss a pneumothorax that's tipped somebody with COPD over into ventilatory failure. You don't need to delay. If somebody's had a chest x-ray in the last 24 hours, you shouldn't delay putting them on because you want to clear a pneumothorax. You should listen to their chest. An ECG, ICU advice: if your patient is for ICU and they're not improving in the first 4-hour period, you need to get ICU pretty pronto. The mask, we have here a full BiPAP mask with the expiratory valves and black straps, because the CPAP masks in Beaumont have blue straps on them. Helen is going to show you the mask and show you how to differentiate between the two. The initial settings given here, 12 and 4, they're very low, but if you were in an exam and somebody says you need to start a patient on non-invasive ventilation, you are going to say, I would start them at 12 and 4. I'd consider higher pressures if they're not correcting and they're a bigger patient. And you titrate. Yeah, this is an important point, actually. When you start somebody on BiPAP, it's going to be clearer when you see the machine. The machine is designed to give positive pressure, not to give oxygen. If you want to give your patient oxygen on top of it, that has to be entrained into the system separately. So you can't dial up the oxygen using the ventilator unless you've actually got it attached to oxygen. A lot of the COPD patients, even though they might be requiring a 50% FiO2, if you've got them on nasal cannula or you've got them on a face mask, you put them onto positive pressure, and actually just the bit of positive pressure, they start to recruit very quickly and they start to oxygenate themselves a lot better. So you might need them on oxygen once you have them on positive pressure. This is where your money is. So common questions on NIV. How are you going to assess a response? When are you going to assess a response? And also, you're going to do this all the time when you're interns. You need an hour of good non-invasive. You cannot, it's taken a long time for that patient to get to a point where they've built up so much CO2 that they're acidotic. You cannot flick a switch and release it all. You can only release it slowly by improving their compliance, by improving their tidal volumes, which is what the machine does. It allows them to blow off their CO2 over time. If you do an ABG 15 minutes after you put them onto NIV, you're going to end up calling anaesthetics an awful lot for shoddy-looking ABGs. You need a good hour of NIV. And that's when you're going to repeat your ABG. Assessing somebody, you can't just do an ABG and take the result over the phone when you're reassessing somebody, because it's not all about the ABG. When you reassess somebody on NIV, you want to know their GCS, you want their repeat vitals, and you want the ABG. That is your complete assessment of somebody on NIV. If your ABG at 1 hour is not improving, it should be clear to you by now that you increase the difference between the top and the bottom number. Don't go from 12 and 4 to 17 and 6 because you have not changed the difference. If you want to go up on the EPAP by 2 centimetres, you've got to go up on the IPAP by at least 3 centimetres. That's how it works. So just bear that in mind if asked to prescribe non-invasive. Oxygenation, if your patient is in ventilatory failure, their SATs are automatically targeted 88 to 92. None of them should be above 94 unless, I shouldn't even say it, but unless you've got somebody with really bad ischemic heart disease and they're getting bad runs of BT, then you might consider oxygenating them a bit more. But by definition, if your patient has gone into ventilatory failure, tighten the SATs. And then the escalation. Any patient, so this is less important for your exams and so important in life. If you see a patient who requires NIV, the first thing that you need to know is what's the recell status. Do they stay where they are? Are they in a side room? Are they going to die? Are you going to move to palliation? Are they going to go to ICU? Are they getting ABGs every 1 to 4 hours? You need to have a plan, because the mortality for these patients, particularly if they weren't acidotic when they came in and then they become acidotic, their mortality is about 33%. That's a lot. That's about on par with somebody coming in cardiogenic shock following a STEMI, just to put it in context. Okay, any questions? Oh, yeah, actually, I should say this. Another common MCQ. So somebody says to you, you want an intervention that reduces mortality. This is why I bang on about NIV all the time. It's a brilliant treatment for acidotic hypercapnic respiratory failure. It reduces your mortality and your intubation rates by about 50%. Every couple of years, another meta-analysis or another systematic review comes along saying the same thing. It works really well in COPD. The evidence base in neuromuscular disease is not as strong, simply because the cohort is smaller, and also because they've got changes in their chest wall over time that we don't see so much in COPD. But an intervention that reduces your length of hospital stay, your mortality, your intubation, if that is attached to a vignette, your answer is almost certainly going to be NIV. Unless your patient isn't in acidotic type 2 failure, then you have gotten the wrong end of the stick. Final thoughts. Familiarity breeds contempt. You see a lot of patients with COPD. You will see so many of them on the wards that you'll start to think, yeah, even when they get acidotic, they're fine. They're sitting up and they're talking to me. They're not fine. They are cruising for a while, and they will cruise for a while, but you need to take it seriously. You need to take acidosis seriously, because it develops very quickly. Establish a rhesus status early. We've touched on that. If you remember one thing, fix the pH with pressure support. That's how to use it. And also, don't rely on somebody else to know that. I am telling you now for a reason that this is an orphan area of medicine. It shouldn't be, because whether you're a surgeon, an anaesthetist, a medic, you will see these patients. One indication only, acidotic type 2 respiratory failure. That's NIV, nothing else. Can be managed effectively on the wards. They don't need to be in ICU. Ideally, they would be in HDU. Some of you will not all be working in tertiary referral centres. Particularly if you stay in Ireland, you might be in Model 3 hospitals, you might be in Model 2 hospitals, where you have these patients. Well, actually, if you end up in a Model 2 hospital, that's exactly where you don't want to be when you have a patient who requires NIV, only because you might be just a house officer, no registrar on call overnight, L machine, and you need to figure out how to set the thing up because the nurses aren't familiar with it. So bear it in mind, you can't rely on someone else to know how to do it, particularly overnight. Pathways improve performance. A lot of debate about pathways in medicine. If you're interested in that idea of the use of pathways in medicine, I would refer you to, there's a great TED talk by Atul Gawande, if he hasn't come on your radar yet over the Christmas season. It might be nice to do a bit of reading for yourselves that still feels like it's developing you as a professional. But any of his books, Complications Being Mortal, they're all excellent. But his TED talk, he talks about this idea that the complexity of medicine has increased enormously in the last 10, 20 years. You will find yourself working for people who, particularly actually around the time when the NCHDs here went on strike to work shorter, or to limit the length of our shifts to 24 hours, some of the consultants were quite unsympathetic to the case that we were making. And really, you cannot, it is comparing apples and oranges if you're going to try and compare the NCHD experience, the non-consultant hospital doctor experience today to what it was 10 years ago, to what it was 20 years ago. It is so much more complex. What we can do and what we do is just, we do an awful lot more these days. So pathways for this, because it's really not difficult. Like titrating non-invasive ventilation, when you compare it to something like 12-lead ECG interpretation, this is child's play. This is easy. It's just that we're not particularly familiar with it. When we're not familiar with something, we tend to pull away from it. You need to lean into it, because God knows these patients are everywhere. Okay, right. Questions about that? Go ahead, in the middle.
Why low pH?
A relative, yeah, okay, so that is a very low pH of less than 7.15. Why do you think? Okay, So say I had a patient who was 60 years of age, COPD, first time he's come in with an exacerbation requiring non-invasive ventilation, or first time he's come in and he's acidotic. He's otherwise fit and well, he smokes too many cigarettes, but he drives, he does everything for himself. Why might I think, less than 7.15, I don't know if I want to go with non-invasive. What might I consider other than non-invasive ventilation? Does he need to be ventilated? Does he need ventilatory support? Catherine is nodding. The rest of you are not nodding, but you should definitely be nodding. He has too much CO2. He's got an acidosis. You need to ventilate him. So if you're not going to ventilate him non-invasively, how might you ventilate him? Invasively, yes. So somebody with a starting pH of less than 7.15, because the mortality is very high, particularly if they're fit and well outside of this episode, you would go quickly to intubating them rather than waiting for them to fail a trial of NIV. Does that make sense? Okay, but again, it's relative. Similarly, if you had an 80-year-old, very poor functional baseline, he's in and out all the time on NIV, and he comes in with his pH 6.9, you put him onto NIV, no problem. You know that he's not going to be for ICU, that it's not an issue, but it is a relative contraindication of very low pH, only because you don't want to waste time non-invasively ventilating somebody if you should just get them on the vent. Yourself, the blue? The EPAP. Yeah. So the benefit of increasing the EPAP is, so if you go back to kind of how I explained what the EPAP does, it splints open those small airways and it improves oxygenation. If you were going back to see a patient and their PaO2 is still really low, or more than that, their SATs were staying really, really low, you might consider going up on the EPAP by 2 centimetres. I would not, I'd say to you, that pathway explains what to do with EPAP, because you would still need to increase the difference between the two, but you shouldn't be really putting somebody's EPAP above 6, really, without talking to somebody in respiratory. But if somebody is persistently really, really hypoxic and you're concerned about that, you could justifiably go up on the EPAP. Just make sure that you're matching or exceeding it with what you're doing on the IPAP. No, never. So when it comes to NIV, when somebody, all you need to see is that the pH has gone the right way. So once the pH starts to turn, and it doesn't matter how small the magnitude of that change is, if it goes from 7.35 to 7.36, that's enough. You've identified a level of ventilatory support, a level of pressure support that is supporting your patient's ventilation enough that allows them to start correcting themselves. So you don't then wean that. That is the effective dose. It's like if you're trying to make, it's kind of analogous to if you're trying to get somebody negative a litre every day and you get their frusemide to 60 mg per day and that's getting them to the negative balance that you want. You've hit the dose, so stay on it. When you start to wean, and none of you should be trying to wean by yourselves, this is where respiratory service, CNSs, A&Ps come in. The way that we wean is we just give people breaks off it. So when you start somebody onto non-invasive ventilation, the first 24 to 48 hours is pretty much continuous. Then you're going to give them breaks off for their meals and their nebulizers initially, and then you're going to start to stretch out how much time they're spending off the vent. And when you get them to a point where they're doing about 4 hours off the vent, you're going to repeat an ABG at that point and see, have they gone acidotic again, or is their CO2 climbing again? And then when you finally discontinue it, you will leave them off it during the day, they will stay on it at night, and then the last thing you discontinue is nocturnal use. But don't worry about that, and that is higher level NIV stuff that you wouldn't be expected to know or be expected to do without some sort of guidance. Go ahead. How much? Okay. The thing with oxygen is, when you're prescribing oxygen, you are just titrating it to SATs. Unfortunately, it's not something that we can write like in EWS, in the EWS charts, but you're titrating it to the SATs. So when you start somebody on oxygen, and likewise if somebody asks you to do an ABG on somebody on room air and they're sitting on oxygen, you only need to take the oxygen off for about 5 minutes. You only need to have the oxygen on for a couple of minutes before you start to see an effect. So you're going to start them, and some machines will keep it at litres per minute, or you're just dialing up at the wall. You're just going to dial up your oxygen until you have their SATs at 88 to 92%. Other machines, like if you're working in Connolly, this is kind of part of the difficulty with NIV, or what makes it, what makes it kind of tricky for NCHDs in particular, is the variability in the machines, because we move between hospitals that we have nippy machines. Here, you go to Connolly, you've got a Trilogy machine, which is a much better machine, but that will allow you to set the fraction, and you just stand there 21%, 24%, 28%, watching their SATs, and where you get them where you want them, then you just stop titrating the oxygen. But all of them should be 88 to 92. Anything? Go ahead. You can change them both together. It's just you have to make sure that you increase the difference between the two. So if you're going to go, like you wouldn't go, like I said, from 15 on 4 to 17 on 6, but you could go to 18 on 6. So you've changed both, but you've changed 1 by 3 centimetres and 1 by 2. Does that make sense? You wouldn't, you shouldn't have to change the EPAP too much. You shouldn't get too bogged down in the oxygen side of it, because like I said, the machine will fix the oxygen for you. And if you're really, really stuck, like particularly if you've kind of difficulty understanding, or you want to try and streamline the concepts for yourself, you can always just entrain oxygen rather than adjust the EPAP. I much prefer adjusting the EPAP. I think it's physiologically a much nicer option if you can actually recruit them and allow them to improve their oxygenation themselves, rather than just drying the heck out of them with a load of oxygen. But you can leave the EPAP alone, particularly as interns overnight. You can leave the EPAP alone. I mean, it says there EPAP should be adjusted with specialist input, but you can leave the EPAP alone and entrain oxygen into the system. That's perfectly fine as well. But titrating the EPAP is more physiologically sound than just giving them additional oxygen. Anything else? Go ahead. Okay, so about 10% of your patients with COPD will have just chronic ventilatory failure. But this group surprises you in that, they will be, it's funny, the patients that you see on the wards here, they almost self-select out for frequent attenders, that they're the patients who are coming in and out of hospital all the time. These guys come in and out of hospital all the time. It's why it's really important to have a resus plan for them and know exactly what you're doing with them, because they're probably going to be back in with you 3 months later if they manage to get out from this admission. There's a real nihilism around ventilating COPD patients, because they tend to be, or they're almost invariably older and invariably comorbid, but they actually get off the vent more frequently than you think that they're going to. It's not like ventilating somebody with COPD with an FEV1 of 30% is not like ventilating somebody with cystic fibrosis or somebody with ILD with an FEV1 of 30%. They're completely different beasts. They do tend to get off. So you will see these guys, you will see more of them survive and get out than you will have die under your care on NIV. If it looks like somebody, one of my worst nightmares would be to die on something in a hospital where it's strapped to your face and you can't talk to relatives, you can't engage with your family so much. People shouldn't really die on NIV. If it's looking like it's going one way and no matter what you're doing, their pressures are up really high, it is kinder to that individual to then look to comfort measures if you're not going to get them onto a vent. Okay? All right, so now Helen. Okay, so Helen is a candidate A&P. I'm going to let her tell you what that is, but it is worthwhile being aware, so please note she is in this sort of green hued uniform. That's what an A&P wears. There's a lot of, like, some of you will be aware of the PAs coming in. There's a lot of new roles coming into the hospital. Certainly by the time your consultants will be much more established. She is part of the kind of first generation of A&Ps in Beaumont Hospital. And it's great to have people like Helen engaging with this and helping us along with how to navigate this. But Helen is going to take us through the machine and the practical aspects. Okay?
So I'll just explain a little bit to you about the machine, and then if you have any questions at the end, let me know, and we might do a demonstration and you can try it out for yourselves and see what you think. So in terms of the machine itself, I suppose there's a couple of points to make firstly. You've established that it's indicated, that there's no contraindications to the use of this therapy. The next thing is about preparing the area. So whatever ward that you go to, maybe a non-respiratory ward, you should really bear that in mind and think about what you're going to need. So preparing the area is the first step. So the patient needs to be in a high visibility area. That's critical to the success of the intervention. So they should be moved to a high dependency area. So your role as interns and as NCHDs, that's where the leadership and the communication piece will really come to the fore. So speaking to the nurses on the ward, explaining that this is what your intention is behind treatment and moving them to a high visibility area, critical to the success of the intervention and the patient's tolerance of it. The patient naturally is going to be very frightened, so if they're in a high visibility area, there's a degree of reassurance that affords to the patient. So the second thing to do is to make sure that you have your equipment assembled. So St. Paul's ward is the respiratory ward here in Beaumont Hospital, and that will have all the equipment you require for BiPAP. So in terms of what you're going to be given, you'll ring St. Paul's ward, and you can see on the BiPAP pathway that Ciara showed earlier, the contact details are available. You ring St. Paul's ward, and they will give you this equipment. They'll also supply you with the documentation that you're going to require to keep at the bedside with the patient. So on St. Paul's ward, they keep the NIPI-3, so this is the BiPAP machine that we use here in Beaumont Hospital. It comes with different pieces, which the nursing staff of St. Paul's ward may or may not assemble, so it's important that you yourself are familiar and can assemble it independently if necessary. Remember, particularly on non-respiratory wards, the nursing staff are going to be looking to you and relying on you to ensure that the assembly is correct, and imparting that information to them is critical as well. So what you're going to be given when you go to St. Paul's ward, you'll be given this NIPI-3 machine, as you can see here, which I'll go through bit by bit. A filter, which you can see here. Now, I always say all these things can only connect in one direction, so you can't make a mistake. So filter to the machine, and then from the filter, the tubing. So you can see the tubing like so. Very important, oxygen. So you would be surprised how many people neglect to connect oxygen. So oxygen, which can be, think of it, must be beside the patient, so entrained close to the patient. So the oxygen connector and the face mask. There's 3 sizes of face mask available for patients, small, medium and large. And again, from a nursing point of view, I would say that's critical to the tolerance of the device. It's also important in terms of the efficacy of the treatment because it ensures a good seal. So you can see if there's any confusion, it's written on the outside of the mask device itself, but also you can see underneath here, medium. So small, medium or large. In my experience, tends to be medium mask that we would select. Very important, a BiPAP mask has grey clips, a CPAP mask has blue clips. You only want the mask with grey clips. You can also see here that this is vented. That is very, very important. You must select a grey mask with a vent. Very important. You can see here it comes assembled with the head straps so that it's not as confusing. And there's one clip which you can release like so. Okay. So once you have all your equipment, you're going to bring it to the bedside. Keep a trolley close to the oxygen point, specifically for your NIV treatment. Remember, these people we've already established have acidotic type 2 respiratory failure. It's likely they're going to be on bronchodilation, so think air-driven nebulizer. Again, another common pitfall at ward level, particularly on non-respiratory wards. They will not think of air-driven nebulizers, but it is important. So you should look to the bedside and ensure that you have that there. Another key success factor is around explaining to the patient what it is you intend to do. So many times over the years I've been on wards where people get so preoccupied by looking after this unwell patient and trying to initiate treatment that the communication piece is lacking. So the communication is twofold, with the patient themselves and then with the nursing staff. So everyone is confident and clear what the plan of care is, and also, as Ciara alluded to, what is the ceiling of care for these patients. So that's clear from the outset. In terms of explaining to the patient, it's very important that, number one, they realise that they're being monitored at all times. It will impede their ability to communicate. They have a mask on their face. So it's important that things like the call bell are left beside them so that they can access help as and when they require. They're not initially going to be able to eat or drink, so that should be in your mind also, that these patients' nutrition and hydration over time, if they remain on continuous therapy, may be compromised, and that's an area to address. So when you go to the patient, again, in terms of explaining the therapy, an analogy that I often used was to imagine if you were driving in a car that was moving at pace and you open the window. And often people will say the sensation feels like that. So naturally, if you're very breathless, very fatigued, very tired, it seems counterintuitive to put a mask over your face. But again, explaining the rationale for why you're using this treatment, that it's going to be on continuously, but the benefits that it can yield, most patients will agree and cooperate. The second strand that I would mention in relation to that is sitting with the patient once the mask is applied. So when applying the mask, I would always say, let the patient themselves hold the mask if they're able, and don't strap it to the patient's face initially. Just let them place it gently over their face. That gives them a sense of control over the intervention until they feel that they can tolerate it. Only at that stage should you attempt to secure the mask. Securing of the mask should be a two-person job, so ideally either yourself and a staff nurse or two staff nurses. Don't attempt to do it by yourself. Remember, you're going to leave the ward. So it's very important that the nurses feel competent and confident that they're going to be able to manage this patient effectively in your absence. So again, when fitting the mask, there's only one way you can do it. Clip it open and it'll secure like so. So again, explaining to the patient that it's important they stay on it. Now again, another rule of thumb, and even when I was a staff nurse many years ago on the ward, I would often sit with the patient. So perhaps when you're writing up the plan of care, when you're documenting in your BiPAP pathway, sit with the patient if it's at all possible. Because often it's that 10 to 15 minutes initially, reassuring the patient, letting them know that you are there and that they are doing well on the treatment is the key to success. Many times I've seen people rush that period, and the patient after 10 or 15 minutes will take the mask off and will be insistent that they're not going to use it again. So it really is key to spend that time with the patient, reassuring them. In terms of the device itself, make sure that it's switched on and that you have your oxygen flow. Again, for COPD, we're going to maintain and titrate the oxygen to maintain SATs between 88 and 92%. Remember, particularly on non-respiratory wards, that won't necessarily be understood. So it's important that you explain about the necessity of continuous oxygen saturation monitoring. So they should have oxygen saturation monitoring in progress at the bedside continuously on this treatment. Again, there's a nursing observation chart. It's important that this is completed at hourly intervals, and then the early warning score as per hospital policy. Make sure that you switch on the machine and that you ensure there's flow going through it and that your oxygen is connected before you attempt to secure it to the patient. So in terms of switching it on, it's very straightforward. Press the power battery and it should switch on. So you can see, I'm not sure what you can or can't see, but this is attached to a plug. So we always attach it to the mains when the patient has BiPAP therapy in progress. The only exception to that will be if they require transfer off the ward. Now, in real terms, the only instance where I can think that has happened is where patients are going to be transferred to intensive care. If somebody needs, for example, chest x-ray, it would be portable in most instances. So there is an internal battery, if necessary, if you do need to move the patient off the ward. But when on the ward, it should be plugged in. So we have an IPAP and an EPAP. Again, whatever settings are prescribed by your registrar, do not assume that the nursing staff will change the settings. Do not assume that the registrar has changed the settings. Always satisfy yourself that they are correct and that they're set and that they correspond with what has been prescribed. If something alarms, always check, why is it alarming? You'll be surprised how many people will just silence an alarm. Check and see what's causing the alarm. So in this case, it's because I don't have it plugged into the mains. So you'll confirm the IPAP and the EPAP. If you need to change that, so you've found that the patient after an hour is not improving and a decision is made to increase the IPAP, you will unlock the machine. There's a lock. So you press the plus and the minus together, and that will unlock the machine. And then you can press either the IPAP, in your case, which is the one you will be usually adjusting, and you can increase or decrease as necessary. Important after that that you lock the machine again by pressing the positive or the plus and minus button to ensure that it is locked. Satisfy yourself that that is done before you leave the patient. In terms of troubleshooting, so particularly on a non-respiratory ward, you could get a call every 2 minutes, the machine is alarming, we don't know what to do. So again, spending that time with the nursing staff before you leave the ward should actually help in terms of you not getting those unnecessary calls. So high flow alarm tends to be that there's a leak. Somewhere in the system there's a leak. Because naturally there should be resistance if it's actually going to a patient. So in terms of leak, check your connections. Make sure the mask itself is actually not damaged. Unusual, but can happen. But make sure that your connections are all secure and that it's a closed system. Low flow alarm. Couple of things you want to look for there. Make sure that it's not kinked. So you will be surprised again. Suddenly you find that the tubing is behind the bed. You get a call, low flow alarm. It's something really simple like that. And sometimes patients' positioning. So if the head tilts forward, sometimes that can affect the flow. Tracheostomy patients, consider the airway. Make sure that you have a patent airway. So low flow means there's an interruption with this positive pressure. So think about what could cause that interruption to flow. Again, tracheostomy as a side point, these patients with tracheostomy would need a heated humidification to be entrained through this system. Anything now that I've forgotten? Troubleshooting? Yeah.
Okay, when you look at the interface, it really is foolproof. There's a button that says IPAP, you hit it, there's some arrows that go up and down, you hit them till you get it at the level that you want. Now Mashari is going to put on the NIV.
So in terms of fit, how we know it's good, it should go over the nasal bridge and sit on the chin. Okay? Very important that you watch for nasal bridge ulceration. So that's very key. So it should be taken off at intervals by the nursing staff and monitored just to make sure that there's no evidence of skin breakdown. So you can feel it firstly. So again, and you can hold it. So I would always say to the patient, hold it up against your face firstly so that you can get a sense of what it feels like. We have it connected to oxygen. Just have a feel of it. Oh yeah. So how does that feel?
Not very comfortable.
Yeah. So you can imagine if you were very, very breathless, very fatigued, exhausted, and somebody came with a mask like this and said, put this over your face, your instinct would be to say no. But if you explain the purpose of the therapy and that it's going to reduce the work of breathing and that they will start to feel positive impact, generally they're going to be more accepting of it as a treatment modality. So now you've become accustomed, we've given you a couple of minutes just having it up to your face like that and you're tolerating it excellently. We can see that the fit is good, it's sitting over the chin and onto the top of the nasal bridge. We want to make sure that we get the head strap to fit well. Now I'm very small, so this is where it all goes. And again, you can see why you really need two people, never mind a microphone, for this. And if you fit this well in the beginning, you're going to have much more likelihood of a good outcome.
Okay, so Mashari, I want you to have a feel of that, and then we're going to go up on your pressures and see what happens. So he's at 16 and 4 now. So the machine is, like I said, these are foolproof. You can't all necessarily see this, but IPAP and EPAP are really clear there. Don't worry about the backup rate, about the TI, about the mode, about the flow. Don't worry about it. You want to do arrows and IPAP and EPAP. He's trying to put his glasses on. So that would be another problem for patients. Okay, so we're going to go up on the IPAP. So I'm going to hit the button there for IPAP. It's highlighted. And we're going up. So it goes up in increments of 0.5 on this machine. How does that feel? Yeah. And you can feel like if you put your hand in front of the mask there, the purpose of the fenestrations is to allow the CO2 to come out. If you put him on a CPAP mask on NIV, you have no way for the CO2 to get out of the system. So there has to be, and these are, actually you can leave those open because that's an intentional leak built into the mask. It has to be there to allow carbon dioxide to come out. Okay, we're going to go up another bit. So bear in mind the BTS recommendations for settings is an IPAP of 30. He's at 20 now. See, now I've never managed to get a nippy reliably up to 30 because it starts lifting off your face. Okay, and you can, if you pop your hand back in front there, you can straight away feel there's a lot more air coming out there. How's it feel? He said great. Okay, so we're going to go up another bit. It is really difficult to talk with it on.
See the flow there? Yeah.
It's like the Darth Vader device.
So again, he's at 28 on 4 there. That's just an alarm for high flow. Okay, so why is it giving it high now? Is it just is it leaking at the mask? Okay. So this is the difficulty with the nippy. This is part of the difficulty with the nippy. Some of the machines, if you go up to a very high IPAP and it's just alarming and alarming and alarming, it might just be that the machine isn't great at delivering very high pressures. It's like the NIV is like the engine in a Ford Fiesta, whereas you put them on a NIV using a ventilator in ICU, it's a different story. Yeah, have a little feel of his face. Okay, we're going to go up another bit. Let's see, can we get it up anymore? Okay, so that's 30 on 4. And it's kind of inflating him. I don't know if anyone... Okay. He will have no carbon dioxide left in the system at the end of this. Okay, so that's 30 and 4. Will we just unhook it so the guys can actually hear it?
So very important, or for example, if a patient is vomiting and you need quick release, there. Don't attempt to try and adjust the other head strap.
Yeah,
only here.
Just release it. It's why vomiting is a contraindication, or a patient with a low GCS who's vomiting, if they vomit into the mask. Okay, so you can have a little go of it, or just put your hand in front of it to feel it. That's at 30 and 4, but you can imagine why it's difficult for patients to tolerate. Now's the time to study. You're fully oxygenated. CO2 is gone.
And lock the two together to lock. So you see the lock button there? Yeah. And then if we wanted to lock, so before you would leave the ward, you'd make sure obviously that it's been locked. Settings locked. And the same to unlock. And then you can see exactly. And you can see there's the IPAP, so you'd confirm that and make sure it corresponds with your prescription. Your EPAP. And how much oxygen would we need to connect them on? So it's very important that the SAT's between 88 and 92%. So the oxygen
you went in, gone and changed the oxygen, it's very important that the nurses understand that actually, because particularly in non-respiratory wards, they will think, oh no, I can only give 2 litres of oxygen. So explaining to them, no, you can titrate the oxygen within this range to make sure the saturations are achieved.
So you only manipulate the iPad, right?
Exactly, and particularly at intern level, and it was one of the required classes for our thing, they were to look at the class, but typically in the iPad to complete the pressure support.
So as an intern, I just set it up and I do the iPad and that's it, right?
Exactly, and make sure, for example, that you have your prescription, that it's correct, and that the plans of the ABG has been established, particularly their initiation therapy.
Right.
You should have that in your mind before you leave the ward. What time do I need to come back? In 60 minutes, as the midterm goes very fast. You have multiple jobs all over the hospital, so it's very important the nurses staff know what time you're going to be back, and also when you go back to check with the nurses, have they definitely taken it for an hour? Some patients may have been off it more than on it, in which case the ABG is not going to be representative or yield any useful information in terms of the efficacy of the treatment.
Right.
Exactly, that's the EPAP there, yeah, and the IPAP is exactly, yeah. So the pressure support is the difference between the two. The second is the pressure support, exactly. And that's what you would typically, so the patient, for example, come back to you now, if it's still not improved, it will be the IPAP, that increases the pressure support, so you're increasing the difference between the two numbers. Really, that's more complex respiratory. So it's very important that in respiratory constantly send you as many patients as are on the non-respiratory ward or if you're not in the respiratory team. Encouraging to get an expert in that's specific to respiratory medicine and managing all the complex elements of that identification.
Right. Is there other modes?
Yeah, and again, at intern level, really SPR and respiratory are the only ones who will look at different types of modes. It should always be on pressure support. So the machines, typically when they come to the wards, they're all standard in terms of the iPad will be there, the EPAP, and they will be already on pressure support. So my advice is don't touch it. The only thing that you should ever really have a procedure, potentially the EPAP, much more common is the iPad, and then making sure that it's not.
So what's the most
Do it yourself. Don't ever rely on someone else to do it.
what's the most common pitfall in setting up and putting it on the patient?
Most common pitfalls, patient not tolerating it because it hasn't been explained to you.
Okay.
I would say that that's actually the most common. Because again, as I said, when you're breathless, you can't just use it to cover your face. Just to explain.
Well done, Mashari. Good job.
So when I take breath in, it's twice the time, right?
Pardon?
Times the push the iPod.
Yeah.
My inspiration, right?
Yeah, Kira was increasing the iPad. Yeah, yeah.
No. When I take breath in,
Yeah.
the machine knows if I'm taking breath in and
Oh,
pushes.
yeah, absolutely. So it knows your like the iPad knows when you're inspiring. Yeah,
It tries to push when I'm inspiring.
exactly.
Yeah, I
Yeah.
wasn't sure that I was trying to push when I'm inspiring or I just synced with it.
No, that's what it is. It's kind of almost taking over the natural function of inspiration and expiration.
But when I stop breathing, it just keeps pushing.
I know that's because Kira kept putting the iPad higher and higher. So you had a really high iPad there. She really had you up to 30. I was afraid you might pass out. No, but I know it was perfect. Good job. Well done. Yeah.
Can I say thank you for the session?
Oh yeah.
Nothing.
lock kind of unlocks the mask.
Very important, the clip. So always remember the clip.
Okay, thanks a million, Helen. That was brilliant. So Helen's going to stick around just in case anyone didn't get a chance to use the machine or has any questions about the kind of practical aspects. Guys, shh, we're almost done. We're going to finish up early today, so just 2 minutes, just so that clearly you're pleased about that. We're just going to kind of wrap up really quickly so that everybody knows where this might come up, how it's relevant to the OSCE, and why we decided to do it in one of your OSCE teaching sessions. So as I said, Helen's going to stick around for a few minutes just at the end if anyone has any last questions about the practical aspects or about fitting the mask on, or if anyone wants to see the settings or the machine or anything again at the end, that's no problem. So I suppose with the OSCE, potential stations you could get that might relate to this. So you could get a station where the BiPAP machine is there, all the setup is sitting there. You could be asked to identify what the equipment is, so be able to say that it's a non-invasive ventilation or BiPAP machine. And then also what we may do in that situation is if the BiPAP machine is there, the first step will be identifying what the machine is. And then you may be given a scenario of, a patient's on this machine and they've been on it for an hour and here is their ABG, and we might give you their ABG and we might ask you to adjust the settings, like Kira was talking about. So just increasing, whether it's increasing the IPAP or that'll really probably be like increasing the IPAP and EPAP would be the only things we'd really expect you to do. Other things we might ask you to do is potentially a communication station. So Helen was mentioning there that the communication piece is so important for patients who are going on BiPAP. And I know myself that when I've had patients go on BiPAP during the night particularly, it can be quite frightening for them. They don't really know what it is. It's quite hard to explain. So, and when you're very busy, you're under pressure, your bleepers going off the whole time, it can be hard to find that kind of time. So that's why it's a useful station to practice at a medical school level, 5 minutes where you're giving kind of a succinct information session or information giving session on what the machine is, what its indications are, why they're going to be on it basically, and what maybe the feeling might be like, kind of warning them or setting them up for what it's going to be like so that they don't, instinctively go and take it off because they find it so uncomfortable. They're kind of prepared for that and aware of that. So they would be the kind of stations that you might get. And, what Helen was talking about there, you can look back over the video in terms of the kind of information that you're going to give them about how it might feel. And if anyone who's tried it on or had a look at it there will know that it feels quite uncomfortable on their face, it's quite tight, so things like that, those useful kind of bits of information will be really important. And you could also say that you're going to place the mask on before you strap it up, just so they know what it feels like. So they'd be the kind of stations that you might get. I think it wouldn't be, we potentially could give 2 different types of machines. You might have to identify, a BiPAP machine versus another machine, but I think that would be quite unlikely. I think realistically speaking, it'd be more likely to be a communication scenario, or this is a BiPAP machine, like you have to identify what it is and then answer some questions about it, or maybe titrate the settings. So that's really the only thing that would be, I think, possible for the OSCE. Obviously, it's important as well for MCQs, as you know. Respiratory failure, non-invasive ventilation is examinable, as Kira said, so it's important to kind of have a good understanding of that and be able to answer MCQs on it as well. Okay. So Helen, as I said, is going to stick around. Everybody's welcome to come up and have a look at the BiPAP mask. And I think this is our last session before Christmas, so have a really nice Christmas break, guys.
host has left the conference. The conference is about to end. Your call will be disconnected.